Hi, everyone. I'm just going to open this up. I think I already introduced the mental status exam in the next slide a little bit, but I'm just updating this. I created this video at the beginning of last semester, and there's just a couple things that I wanted to add to this. But what I think I'm going to end up reiterating just with regard to this mental status exam is how often we really use it without realizing it. So, in reading the article that came with the assignment, you'll read about how this is our way of being able to have a framework for sharing objective clinical information that we observe from a client, from a patient when we meet with them. And that really can speak to the person's diagnosis. It can speak to changes in their diagnosis. It can speak to clinical information that can help us in really determining a diagnosis. But it essentially can also change from session to session. And so if we're meeting with somebody and they are pretty stable with regard to their overall presentation, like, when I have my worried well in my private practice, then their mental status exam doesn't necessarily change as far as their mood, their behavior, their orientation, their speech, etc. More or less, they pretty much present as status quo, as unchanged. But there are plenty of times that that's not necessarily the case. When we go through stress and we're upset about something, then our mental status exam components might be different. But essentially, what the mental status exam is it's our way of capturing a snapshot to be able to really speak to how this person is showing up when we are doing clinical work that's separate from the content of what we're doing in the session. So this is like another way to be able to really paint a clinical picture of what we see in doing this clinical work. So like I said, this can actually demonstrate somebody's status, improvements, any sort of decline if they're becoming dysregulated, if they have a schizophrenia spectrum disorder and we see that their symptoms are worsening, then the mental status exam is a great way to be able to speak to that. That again is separate from your recounting of what you actually do in the session. So there's a lot of value to this. Now, I just want you all to know that as we are starting, I know we haven't yet met, but as we start to work together, I just want you all to know that I'm definitely going to give you a lot of content that I want you to know and to take away from this semester that we have together. But I also want you to know that there are lots of reasons that I ask you to study what you're studying, and all of it is going to provide value to you. I'm not going to ask you to do something that just like doesn't really matter, or that there's no utility for it. I just think that you have a lot of busy work to do in life, and I'm not going to be somebody that just adds another log to this, or that just adds more to your plate in that sense. I was going to say another log to that fire, but the point is that this is where there is such high utility with the mental status exam, and I think I take it for granted sometimes about how frequently I use it. But I'm sure that other people can agree or relate to this, but in your experience in the field of studying psychology, for anybody that's watching this video, have you experienced somebody asking you questions about your superpowers as budding psychologists? I know we're not in a psychology per se program, but that's people always categorize it as psychologists. But so, I know since I was in college, people that I've found have just been uncomfortable with the idea of somebody scrutinizing them will ask, "Oh, so what, are you analyzing me right now?" Or joking, "Are you analyzing me right now?" It's like, ha ha ha, no, I'm not. What I have come to say is I only do that when there's a problem. Like I only use my superpowers for good when there's a problem, whether it's in my work life, in my outside life, if I'm just walking down the street and I bump into somebody, which is what I'm going to share with you. That's when I essentially am trying to assess what's happening because I want to understand what's going on. I want to understand if I can help somebody. I want to understand if I'm going to be in a dangerous type of situation, if there's safety factors. Like this is just where, all of my training comes into action. And so I'm going to share this with you all about how the other day when I was walking my dog in my neighborhood, I used the mental status exam. The situation is that I was walking my dog, and it was about 6:50 in the morning. I live in Mission Hills, so if anybody's driven through Mission Hills before, been to Mission Hills, you know that our neighborhood essentially is like on the top of a hill. And if you're coming from Old Town or going up through Presidio Park, you can get to our neighborhood. Or if you're coming from Hillcrest area, you can go through our neighborhood again to go back down to Old Town. So I live on one part. I live in one part of. I live like more of the western part of the neighborhood, and so people often come up from Presidio Park, from Old Town. So there's a mixed bag of people. Usually in the morning, the only people that walk through the neighborhood are people that are also walking their dogs. So what was interesting is I started walking down one street and I noticed that there was a woman who was probably like in her early 20s walking by herself. She was wearing a hoodie and like a spandex skirt. So I don't know if it was like a party dress, like a going out dress underneath that. But she didn't have any other layers. It was pretty chilly. She was wearing like soccer slides and socks, like short ankle socks. And so I immediately was, and she was wearing, and she had a clipboard. She didn't have a purse, like there was no other belongings, but just a clipboard. And I was like, this is weird because who's like walking through the neighborhood conducting a survey? Nothing, didn't look official in any other way. And she made eye contact with me and she came up to me and she said, "Excuse me, can you tell me where the nearest store is?" And I was like, "Store? Like a grocery store?" And she said, "Yeah." I said, "Liquor store?" She said, "No, grocery store." And I was like, "Oh, okay." So I was trying to give her directions about how to get to Vaughn's, which was it's like a mile away, or longer. And so I was trying to give her directions, and she was registering what I was saying. It was a like a normal conversation in that regard, but it was just very odd. And I wanted to ask her all these questions, like, "Who are you? Did somebody take you? Did you escape from somebody? Like, why are you walking around by yourself with a clipboard?" The only thing that I asked was, "Hey, what's that clipboard?" And she showed me, and it was like a page from an adult coloring book, like a mandala type of coloring book. But the weird thing was is that she didn't even have any markers or anything. And she said, "Oh, well, I just thought it would be great to color, and I just thought that that would be a good thing to do." It was just very odd. So I start going through the mental status exam in my head in the moment. I'm noting her eye contact. I'm thinking of her orientation. Where she's not oriented necessarily to place. She's asking me where the grocery store is. I don't know if she's oriented to time. I'm sure she knew it was the morning, but I don't know if she's oriented to the situation, or she's not sharing this. I'm not oriented to the situation for her. I don't know why she's walking through the neighborhood. She just was kind of roaming around. Um, Her speech was good. It was clear and coherent. She wasn't tangential. She wasn't hyperverbal. Her mood was pleasant, stable, but it also was like she didn't seem to be anxious at all. She was almost kind of like her affect, the way that of presenting her mood, her emotions was a little bit inappropriate because it was like 7 in the morning and she seemed like perfectly at ease, just wandering through a neighborhood without a phone, without a means of being able to get directions. Um, I don't know what her thought process was like. I think her judgment was a little bit concerning because I don't think that she really had some said capabilities of being able to actually like. I mean, her judgment was good in the sense that she walked up to me, hopefully a seemingly normal person, to ask me for directions, but there was just something that was off about it. And then what else did I notice? What I was trying to ascertain was like, was she on any sort of substances? Her pupils didn't seem to be dilated to me. That's usually what I look for. And she didn't seem to be responding to internal stimuli. So she wasn't necessarily psychotic, but just something was totally off. And so there was only so much that I could do. I couldn't just stop and do like a full assessment on her. But this is how often I really have curiosity about what's going on for a person is, and it happens often just in terms of like day-to-day interactions with people. But I don't always think about how I'm going through this format that I'm going to talk you through until there's something that is concerning. So maybe I repeated that already, but that's just what I wanted to give you as an example of opening this up. I'm going to talk about just all the things that I used to describe what my observations were. I'm going to talk to you about that, but that's how I wanted to introduce the subject. So I know this is a little bit of a lengthy video. You're going to keep coming back to this at different times throughout the semester. So if you have any questions on it, let me know. But otherwise, I hope that it is useful. And we will talk about another clinical situation and use this information to apply it when we meet in class on Wednesday. Okay, thanks, everybody.
So I am going to go over the mental status exam document that I've put together. And this is something that I really just want to make sure that you have an awareness of this and that you just have a snapshot of what this looks like before we go into class on Thursday, because we are going to be viewing a mock clinical interview, and you'll be taking this document and essentially checking off what the client, Andy, is, how he's presenting. So a recap, if you've already read the article or if you haven't read the article yet, to explain what this is. Basically, the mental status exam is a way to be able to, in your charting, in your documentation about your client, your patient, this is a way to really be able to give a visual snapshot of how your person shows up when you're meeting with them. This is not speaking to their overall symptomology. It's not speaking to just the on and off. It's not speaking to the actual diagnostic definition of what their presentation is. This is what they look like when they're in front of you. This is essentially giving you an opportunity to state your observations. The reason why the mental status exam is important is because in a really short period of time, you can essentially identify different characteristics of how they're presenting, and again, give the reader this visual overview of what's happening in the session. Another reason why this is important is because this essentially allows you to be able to speak to your client or your patients many different ways of presenting. Perhaps every time you see them, they're the exact same way. They're alert and oriented times 4. They have a neat and clean appearance. Their judgment's good, insight's good, concentration's good, like everything is normal. What's useful about this in that example is, like, let's just say that you have a client that's like always really stable when they come in, and every time you do their mental status exam in terms of your session note, it's indicated as such. But then there's one time where your client comes in and they are lethargic, they're disheveled, their insight is fair and it's usually intact, their concentration is impaired, they're responding, well, maybe they're preoccupied, they can't focus. That's really different than what you're usually used to seeing. And so what the mental status exam does, like I said, is in a short space of a document, it shows any sort of changes, whether these are changes that are concerning, changes that are indicating a positive response to treatment, but it's showing that there's something that is fluctuating in your client's presentation. And so there are different categories that we really get to utilize to speak to that. Now, perhaps you have a client that's just always stable, like they're always stable, they're always normal, and that's helpful. If you have clients that are coming into treatment and they are ambivalent about being there, then the mental status exam gives you opportunities to be able to speak to that through different categories. If you have a client that's becoming psychotic and you start to just see different, like, little snippets or nuggets of, that's not the right word I want to use. You start to see little indications of this. That's where the mental status exam can do this. So it's almost like a really both artistic and scientific way of painting a picture of your client. A lot of times you'll see that this is perfunctory, that like people just like clinicians will just like click the boxes. Me having a background in writing, I love the mental status exam because it's an opportunity for you to be able to speak to what you see is happening to your client or to your patient right in front of you, separately from what you talk about in the case notes. Now, the case notes can really be reflective of this, and this is where we can apply the golden thread conceptualization to that, where your client's coming in, and I'm going to go to this example. Your client's Pedro, and he's coming in, and his judgment is and insight are intact. He's alert and oriented times 4, but he's embarrassed to be there. Oh, this was the one where he's actually like depressed, right? Yeah, depressed and anxious. But he's making a little insight, but then he's warming up. Speech is soft but clear and coherent. Mood is depressed, where he's dysphoric, like he's pretty noticeably off. His affect is blunted. I'll talk about all of these as we go through the document, but it's congruent with the situation. He's calm and cooperative, tearful at the end of the session. That's an indication of like, hey, what's going on? What did we actually talk about in the session that would bring up his tearfulness? Psychomotor presentation is calm despite fidgeting with his hands, which can indicate that he's anxious and that he's uncomfortable in the beginning of the session. His thought process is linear but somewhat circumstantial, meaning that it takes him a long time to explain things, or he gives a lot of details before he actually gets to the point, but he responds well to direction. Thought content is appropriate, so we're not seeing any sort of delusions, hallucinations, and he's not doesn't have any sort of suicidality or demonstrating any sort of homicidal ideation. So what you can do is really, I mean, typically in your documentation, this is going to vary depending on where your site is, depending on what your documentation standards are. So I know that I might be teaching you something that you're like, cool, Lindsay, we don't actually apply this in our first year. But this is just something I am taking a lot of liberties zooming out. I'm taking a lot of liberties in this class to teach you things that you will need, that you will use, that you'll be like, oh yeah, okay, I don't remember the specific thing, but I remember in psychodiagnostics, Lindsay taught us this. um, so this is something that typically is used at the beginning of a case note or the beginning of an assessment to give an overview. And then what you would do in your case note is speak to what's happening with Pedro. Why is he embarrassed to be there? Why is he uncomfortable? What's going on where he's so depressed to the point where he's just like really, really having a difficult time with regard to his sadness. And so we can use this to almost give ourselves indications while we're doing case notes of like, hey, I got to talk about this. Like now I've given the overview, I've painted a snapshot of what it looked like through my eyes to see Pedro. And then I'm going to speak to the content to this. I'm going to speak to what we actually talked about in the session, what sort of planning we're going to be going over as we're working together, how we're going to be able to do this successfully in our treatment because of how he's presenting. This conversely, this is another example just to finish this page. I want to give you as many examples and snapshots as possible just so you can get an understanding of what I'm looking for. You're going to have one opportunity to do this in the class where when you do your group video presentation, and you'll have the mental status examination that you have to complete within the written part of your presentation. So this is the one time that you'll actually have to formally do this in class. But I give you these examples for you to know what this is supposed to actually look like, how this is supposed to flow, how all of these categories that we're going to review earlier on in the document actually look when they are written out. In some cases, depending on what your documentation standards are, you might be checking boxes. So with regard to like EPIC, that is the EHR that Sharp uses, and a lot of you will probably be at Sharp just because it's a huge site with a lot of different opportunities. That's something that you're really clicking through. You're not really writing it for most of your case notes. So this is where, again, I want to just help build the foundation for you as to what this looks like and what we're covering. All of these pieces fit together as far as our observations, our observations being building blocks that provides congruence in terms of a patient's symptomatology that go into what a diagnostic presentation actually looks like. So this second example is a really, I wrote this, but is in my biased opinion, a good example of what it looks like if you're going to meet with a psychotic person. Now, not all psychotic people, or pardon me, not all people that are experiencing active psychosis look like this, but this is kind of like a classic snapshot. So Pedro presented to the session as alert and oriented. Again, I'm going to talk about what all of these means. All of this means he's slightly disheveled and malodorous. Now, this is something that we might see with this is something that we see with somebody that has a thought disorder because their overall executive functioning is really impaired. And so their disorganization of thoughts, of planning, of action gets impaired. And what that translates to is their activities of daily living, i.e., how they shower, how they get ready every day, how they put on clothes that match, all of that stuff really gets impaired in the thought disorder. So if we're seeing somebody that has schizophrenia, even if they're medicated, but if they're suffering from the symptoms and you see the symptoms in session, you very well might see somebody who is slightly disheveled, that hasn't been showering, because of the fact that their overall cognitive motivation gets impaired with that particular disorder. So this is another way for me to teach you what this looks like, that when we start to actually go through the disorders, you're like, oh, okay, this makes sense. So Pedro's memory wasn't able to be assessed. This is a typical thing that we might see in a session because we're not necessarily competent, or this is not in the scope of our typical practice to do a memory assessment. This is really more something that we would see with regard to a physician that is assessing a patient. His judgment and insight were fair through the session because of the nature of his thought content. Pedro made little eye contact with me and seemed to be responding to internal stimuli during the intake. Again, this is what we would see for somebody that has active hallucinations, that's actively disorganized. Speech was soft and he mumbled until he was asked to speak more clearly. This can happen because if you have auditory hallucinations, so voices that are talking to you while you're talking to somebody else, something gets impaired. Our concentration gets impaired, our speech gets impaired because we're distracted. That's what active psychosis can look like. And so some sort of sensory or presenting component gets impaired because of how a person is trying to manage their awareness and their attention at once. Pedro's mood was dysphoric, his affect was blunted. So that can certainly affect a person's mood and affect, and that can be a product of medication as well. But this is congruent with the situation because the situation, what this is setting it up for is the situation is that Pedro is probably coming into the session not doing very well because he's actively psychotic. And so we would expect that his mood would be affected. We would expect that his affect would be affected as well. Behavior was suspicious, guarded, and withdrawn. This is an indication that we would use to speak to somebody's paranoid hallucinations or paranoid delusions, pardon me. His thought process was illogical, tangential, and he was likely experiencing thought blocking, as evidenced by, this is the way to shorten that. I don't know where what I was going to say just went. I don't know where what I was going to say just went. That means that with thought blocking, that thoughts just basically disappear. This is what we see in psychosis, and this is also what we see in cognitive or neurocognitive issues as well. Pedro admitted in the session that he had paranoid thought content, as well as ideas of reference and magical thinking. I'll talk about that. He denied any hallucinations, but it was evidence per his behavior that he was experiencing auditory hallucinations during the session. due to responding to internal stimuli. That sentence might be a little bit redundant, but I'm just over explaining to be able to give you a clear picture. His psychomotor presentation was restless, as evidenced by his right leg shaking throughout the session and fidgeting with his pen. This could be, again, nervousness, and this could be something that we also see as a side effect to medication. And then Pedro denied any sort of current SI or HI as confirmed by his wife. So the last two sentences I don't actually cover in this document, but this is just the note that we always want to, in the mental status exam that we write, we always want to make sure that we're speaking to our awareness of their safety issues. So this is like the reminder that we need to do a safety check within the scope of our practice, or that we need to be able to know if they're suicidal or not, or if they're homicidal or not, and include that. Okay, so I'm starting with these pictures. Now I'm going to go into, or these images. Now I'm going to go into the categories and the components. So in this document, I do my best to have this be as like linear as possible in terms of addressing like what goes where. But there's a couple of them that just because of like spacing issues when I was putting this together are a little bit out of order. Either way, we're starting with much more like surface level observations, and then as we get further down in the document, it's going to a deeper thought content issue. Okay, so the level of consciousness and orientation, this is what you're going to hear so often, whether you work in a clinical setting, if you end up ever working in a medical setting, this is what medical practitioners, nurses use to be able to describe a patient's presentation. So alert and oriented times 4 is that we're fully awake, we're normal, and we know who we are, we know where we are, we know the date and time, and we know why we are in the situation that we're in. That is a normal, stable presentation. So alert and oriented times 4, or I hear this with the nurses that I support when I'm on the ICU, or just, hearing people talk about patient-related stuff, is that they're ANO times 2, ANO times 0, because of the fact that I'll tell you more about what I do when I see you all on Thursday. But because of the fact that I am around patients that are in the ICU a lot, because I support that unit in particular, our patients are ANO times 0 because they are in a coma, basically. So they are not alert at all. They are not oriented because they are not awake. Not funny, but basically this comes with the territory. So they don't know who they are. They don't know where they are. They don't know the date and time. They are just in a deep slumber. When we have patients that are like coming out of any sort of medically induced coma, this is not really what we call it in the medical setting, but when they're essentially sedated, um, or they're on some sort of like chemical support through medication, then they're coming out of this, then they're reorienting. So we had a patient in ICU who was basically in a coma for 2 weeks, and just started to, we took his breathing tube out and reduced the medication that he was on so he could become more alert and awake. And he kept asking who he was. His family was in the room with him like all day on this past Friday when I was there, and he kept asking his name, who he was. So he was alert. He was fully awake, but he was oriented maybe times like a half, but he didn't know where he was. He didn't know the date and time. He didn't know why he was there. So the hope when I go back tomorrow is that he's going to be more reoriented. Maybe he'll have a better sense of who he is. This really happens. This example is like totally out of scope of what you're going to see in your practicum settings. Again, it just depends on like if you work in a medical situation later on. But this is like an example of when somebody is cognitively impaired as a result of a bigger issue. They're not going to be oriented times 4. Most people are going to be alert and oriented times 4 when you see them. Now, it's very possible that somebody could be lethargic but still oriented times 4. Maybe they're drowsy because they haven't been sleeping. They're drowsy because of the medication that they're on. They're drowsy because of some other issue. you're rarely going to see somebody that's like obtunded. Somnolence is when somebody's like continuously sleeping. And again, this could be a medication issue, or this could be under the influence of opioids. I learned that like really early on when I was a trainee, that I had a client's aunt come in who I knew had a history of opioid use, but supposedly she was sober and she kept falling asleep at like 3 o'clock in the afternoon in our session. She's like, I'm sorry, I'm just really sleepy. And I was like, why is this woman so tired? And then I realized, like, oh, because she's high. So there could be a lot of reasons why a person is presenting the way that they are. At the beginning of your practice, you're not supposed to necessarily know why, but we are essentially trying to just track what's happening and describe what's happening through these different categories. Now, it's possible as far as orientation, again, due to any sort of cognitive impairment, due to some sort of thought disorder, that a person may not know why they're in a session, why they're there in the hospital. And so we put oriented times, however many times they're actually checking out, like oriented time person, oriented times 3, so person, place, or time, and time, pardon me, not oriented to situation. So we just have to identify what is off as far as their awareness about all of the factors that are going on in the moment. Okay. Um, and there's one other thing I was going to say about that. I'll get back to it. Oh, I have a client in my private practice who had, again, this is a rare thing probably, but who has dissociative identity disorder. And when she dissociates all the time in session. But when she goes really deep in terms of uh, herself, there's a deeper way, there's a bigger way to explain this, but when she gets really disconnected, like associates pretty deeply, I'll have to like yell her name in the room to get her to come back. And then she looks around the room because she doesn't know where she is, because she's lost track of time. And so she's like reorienting herself. So I see her look around the room and she's like noticing my office. And then she'll look at me and I'll say, hey, welcome back. And then she's reorienting to her place, her time, and the situation. She knows where she is. She'll put it together that she's in the session on a Wednesday night at 5:30, and then she knows the situation that she's in session. So that's a pretty standard thing, but I just have to speak to it. It doesn't happen all the time, but it happens most often. Okay, so concentration and focus. Most of the time, we're going to see people that have no focus issues. Now, if a person has some sort of impairment or some sort of impairment, then it could be fair, where maybe the concentration goes in and out. This could be like, if we have a fair concentration or focus, we could be just distracted. If you have somebody that has ADHD, maybe that might be the case. If you have somebody that's really stressed out, anxious, depressed, I mean, there could be lots of reasons why somebody is not fully focused in the session. So again, it's not in the mental status examination section. It's not up to us to essentially identify why, but we're just checking the boxes of what's actually happening as an indication or a marker for us to continue to speak to that later on in the notations or the documentation, pardon me. If somebody's focus is impaired, then it's like noticeably impaired, that they're really distracted in and out. You have to keep redirecting them. They could be preoccupied, so they're like really unable to focus. And this is what we start to see with more of a thought disorder presentation or something like a neurocognitive issue, like any sort of dementia, that they don't have the capability of staying present and in the situation. If somebody's under the influence, then that could be the case too, that they really can't focus, and we shouldn't really be having sessions with them at this point either. And we could talk about that later if you guys have questions about that. Is when do we actually decide that we're going to try to stay in the session, or how do we really manage our expectations about what we do in a session if somebody can't focus because of something that is happening independently, which is like naturally happening based on their pathology or because they're under the influence of something. Most of the time, if they're under the influence, we really won't have a session. But so if they're preoccupied, then that might be that they actually have some sort of thought content that's happening, that they have auditory hallucinations, or there's like what people also report is that they have like whispering, but they just can't stay with us because they're attending to what's going on. Now, if we really see like a marked re- uh, responsiveness to internal stimuli, then we would just put that they're responding to internal stimuli. So sometimes it's really concrete where they're really, and another indication is that they're talking to us, but they're like looking behind us, almost like they're, if you think about it and somebody's talking to you while you're also trying to have a conversation with somebody else, it's our brain's way, like when we look like behind somebody, like a 1,000-yard stare, it's almost our brain's way of being able to try and simultaneously register what's happening. That's an indication when you're in a session with a patient or a client. If they are looking away from you, past you, then they might be responding to internal stimuli. In the video we see, this will be an example. But essentially, the focus is directed toward auditory hallucinations. So I shortened it as AHs, as if they're mentally responding to them. Last time I paused, oh my goodness, sorry, I'm just recording this at home and my animals keep needing things. Um, okay, so appearance, we have different options of how somebody's appearing. It's just important to be able to identify what that looks like, again, to give a visual. So I know that malodorous is not an appearance, but this is just put in that umbrella of a category to give another element of how a person is showing up. And so again, I say ADLs, which means activities of daily living. There are other components that go into activities of daily living. Like again, that's if a person is getting up out of bed, they're showering, they're eating, like there's a bigger scope of that. But this is just a colloquial way that we speak to a byproduct of that. So if they're malodorous, then we put that as ADLs because that indicates that they're not showering or they're not showering very well. So a person, just given the nature of their pathology, they might appear older than their chronological age or younger than their chronological age. It just depends on how they actually are presenting themselves. Younger than stated age is not due to any sort of medical issues. It might just be of how they're dressing and how they're trying to present. Like they're really making inappropriate fashion choices, which again can speak to a type of pathology, whether that is a personality pathology or my mind goes to personality stuff. It just depends. But so this is like an Easter egg, if you will, of us being able to um, Um, so it just depends, but this is just an Easter egg to speak to what might be happening. So judgment, most people have intact judgment that like, and the just judgment question is like, hey, would they be able to know how to manage their basic safety issues? Like if in a situation of like, this is less about their pathology and more about just like the general stability of their cognition, of their brain. And so if they are not intact with their judgment, they might be having some sort of neurodevelopmental issue, that they have an intellectual disability, or there's something, again, maybe neurocognitively that's happening, like dementia. Like, I mean, Alzheimer's would be pretty severe too. If like, why would there be smoke? Because they're not connecting to really concrete elements of being oriented to person, place, situation, time, etc. So we just have to identify like, hey, does this person really seem to know what's going on in the session, in the world? Or is there some sort of impairment just in terms of their basic decision making? That's really what the judgment is like, is their decision making, executive functioning impaired or not? Now, insight is a little bit different of like, hey, do they get what's going on, why they're in the session? So if a person understands why they're receiving treatment, they get their clinical issues, then they would have intact insight. It doesn't mean that they are fully motivated, but do they actually get why they need to be there, even if they don't want to be there? Perhaps they have fair insight where, like, fair and impaired would be for those people that don't understand the nature of their disorder. So I had recently a client in my private practice who is increasingly more delusional, and I can speak to this as a further example on another page, but increasingly more delusional. And the problem is that they wouldn't take any medication. And so at some point, I always say this with my clients or patients, is either telling them directly or telling their loved ones that at some point the nature of delusions is that it's progressive. The nature of hallucinations can be progressive too, but we especially see this with delusions, and the walls start to close in on them because more and more people become part of their delusional content. And so my client unfortunately does not really have a lot of insight about why they need to be taking medications. They don't have a lot of insight about the fact that their delusions are delusions. They very much perceive that this is something that they are experiencing and everybody else is telling them that that's wrong, that that's what they're experiencing is. My client always would say, like, I know you think I'm crazy, but this is what's happening to me. Like, the government is actually out to this, is following me. They're reading my thoughts. They're putting people against me. Intact insight would be like, I know that this very real experience to me isn't actually happening, but it feels very real. But I get that the reality of this is that this is in my head. Unfortunately, when people are not medicated and the psychosis becomes increasingly more progressive, or pardon me, the disorder, the delusional disorder for him, it was really schizoaffective disorder. When that becomes increasingly more progressive, then the the walls closing in on them actually, unfortunately, can look like fair or very impaired insight, which makes it so difficult for us to be able to provide treatment. Because in this example, if somebody perceives that this is happening and that everybody is thinking that they're crazy, but they really are having this go on, this is really happening to them. My client didn't want to take medication because he was like, why would I take medication? Like, this is going on. Like, that's not the problem. That medication isn't going to fix these people that are surveilling me. So trying to do some what we call reality testing with him, but it unfortunately was not very effective. And so the reason I'm not treating this person anymore, in short, is because they weren't not able to agree to medication. And the more I pushed on this, the more they were resistant, and they ended up firing me. And so now I just have to pray that they're going to be okay and that they'll get the treatment that they need. Unfortunately, it's to a point where it's going to be involuntary because this is not about them making choices anymore. It's not about him deciding, oh yeah, I get that it's probably in my head, because of the nature of that progression. So insight is really important to speak to, depending on especially the nature of their presentation. Insight can be important to speak to why treatment is going well or why treatment might be very challenging. Because if they don't have a lot of insight, then they're probably not going to be very collaborative in engaging in the treatment process. Now, recent or remote memory, this is if you have the ability just in sitting with them to ascertain if they have any sort of like issues with recalling recent things, or talking about childhood, talking about just historical information, it's not up to any of you to do a formal memory test unless you're trained in something like the MOCA, which you might be at some point in the future. But so if you have the opportunity to be like, yeah, I think that they're from based on what we're talking about, I've given them like a whole behavioral health assessment, they have no issues in recalling important information, then we would say that it's intact. But if you are unable to assess, then that's understandable as well. If it's impaired, that can just be arranged depending on, it's not up to us to have to like specify that, but just impairment is impairment. Of like, I don't remember my childhood, then you could say that they would have impaired remote memory. And eye contact, I skipped over that one, but that comes with the territory of different types of presentation. They might avoid, culturally appropriate is that they make eye contact with us. They don't stare at us the entire time, but they're making eye contact. Now, if they're avoiding, that might be because they are embarrassed, sad, ambivalent, anxious, etc., or it could be for other reasons too. If they're demonstrating intense, then here, I hope you like my Calvin and Hobbes example. That might be due to so funny. That might be due to what we could see in sort of in a schizophrenia spectrum disorder, or something that's neurocognitive, neurodevelopmental, that they don't have the ability to identify that it's not, most cultures are not comfortable with somebody staring at you intensely, right? Like that's not appropriate. So we just have to speak to what their eye contact looks like. And so down here on the first page, I gave you another example of what this top part of the mental status exam looks like. Jill presents to the session as alert and oriented ×4. Her concentration is intact. Her eye contact is appropriate. Jill presents as neat and clean to the session. Her judgment and insight are also intact. I was unable to assess for her recent or remote memory, but she had no difficulty remembering information during the session. So that's one way to be able to describe this. Oops, I skipped. Okay, so speech. There's so many different options of how a person is actually speaking in the session, where we get to describe that without giving a lot of direct quotes in the mental status exam paragraph. But typically, if somebody is stable in this regard, their speech is going to be clear, coherent, easy to understand. I know sometimes I mumble, but typically my speech is clear and coherent. It's easy to understand, articulate, it's logical, it makes sense. If somebody has spontaneous speech, that might just be that they're comfortable being able to be conversational. Or if it's spontaneous, it might be that they speak up in the middle of group, in the middle of your session, and like that's not indicated for them to talk. But you would just want to indicate other components that go along with their presentation in the as far as what the mental status exam offers for you in terms of behavior, as far as restlessness, etc. So let's see, what was the other thing? So if a person is not coherent, they're not logical, able to understand in terms of their thoughts, and that might be incoherent, loud, mumbling, mute, silent. So they're not speaking despite prompting or urging. Neologisms, that is what we would see as far as like more advanced schizophrenia. We would also see that in terms of, I hope you're seeing a pattern. It's like schizophrenia, neurodevelopmental, or neurocognitive issues. So something that is happening with the brain shows up in terms of thoughts, it shows up in terms of speech, it shows up in terms of behavior, it shows up in terms of appearance. So any of these three categories that are impacting a person's ability to think clearly, to be able to engage in their executive functioning, to be able to sequence their actions and have those actions be things that create productive behaviors. Um, all of that stuff is potentially impaired based on any of those three umbrellas of a presentation. So they have an intellectual developmental issue, they have something like either dementia, or again, we would see this in terms of Alzheimer's, and also, like I said, schizophrenia. Those are all going to be impacted. So it just depends on what a person is presenting with. But neologism, poverty of speech, word salad, those are all going to be things that we could see under those categories. Now, pressured speech, this is what you would see in somebody who's manic, where it's almost like I always envision this like there's somebody behind them that's like pushing the words out of their mouth, that there's like a pressure to talk. That's where we get the term pressured speech. There's pressure to talk. This is rapid, continuous speech that often is very difficult to interrupt. Oh, and I'll show actually another example of what that looks like in class. After we do our practice round, I'll show you another example of what pressured speech is, which is it's really difficult to manage. And again, that kind of falls under the category of like, what are we doing in the session with them? How are we really trying to like manage their behaviors if we can't have a back and forth conversation? So I gave you underneath this category, I gave you different spectrums of what this looks like in terms of the rate of speech. So pressured, hyperverbal. I had a client in my sessions on Friday who was a new client to me, and she basically talked the entire time. And most of the time I couldn't really get in too much of like thoughts, feedbacks, questions, because she just really wanted to explain everything to me. Now it wasn't pressured speech because it wasn't so rapid, but she was just like a long talker. So that's where we could, hyperverbal is for the long talkers of the world, okay? Regular, normal rate, back and forth conversation, slow, delayed, or mute. So that's the rate of speech from one extreme to the other. Clarity, again, from one extreme to the other, would be clear, coherent on one end to mumbling, to stuttering, slurring, to like totally incoherent, where you're like, what is this person saying? So that, again, might be a thought issue. That might be something that's happening independently within their brains, that there's a reason why somebody, or under the influence, that's what we would see if a person is like really effed up, pardon my pseudo French. They could be incoherent because again, something is like really disconnected in their brain that is impairing that part of their brain where they're trying to speak. So mood, this is the presentation of what emotions they're having, okay? Affect is how one demonstrates their emotions. So mood is like, what am I possessing as far as how am I feeling? The affect is like, how does that actually come out? How do I demonstrate that to you? So we have different category or different options as far as mood, anywhere from angry, anxious, content, which is on one end, and on the other document, pardon me, on the next page, I think I have another spectrum to show you where this can go. Depressed, despondent, dysphoric. This is all in the realm of sadness, and it goes from depressed to dysphoric or despondent, where like it's like persistent dissatisfaction and unhappiness. If I'm meeting with a person that's dysphoric, they cannot be cheered up. Um, or sorry, despondent, they cannot be cheered up. Now, dysphoric is like they are persistently unhappy. Maybe they can't be cheered up, but despondent is like, I can't really tap into that. They'll listen to me, but their mood isn't really going to change. Euthymic is on the other end of the spectrum. Elevated, this is like a sustained high mood that we would see, that's probably incongruent with the situation unless they like got the best news, or they're just like, just, you know, had a baby or like something so fantastic. They might have elevated mood, but it could be incongruent with the situation depending on what's going on. Euphoric is it's like they're on another level. This is what we would see in somebody that's manic, or I know it said like a high, they could be that they are in fact high. It depends on what that euphoria is, where that's coming from. Full range is that they're capable of any emotion appropriate to the situation. So they might go from like coming into the session pretty content, and then they break and they're like, oh my gosh, I feel so guilty about what I did. And this is making me feel really, really sad because I hurt somebody's feelings. And it makes me feel sad because it makes me think about when my mom died and we had just gotten in a fight. And I just feel so terrible because that's how we left things. And now I'm thinking about my mom and I'm crying because I just miss her so much. And she died 2 years ago. And this is just tapping into my unresolved grief, yada, yada, yada. Now, if I said it that way, what would my speech be like? It could be that um, it could be that my speech is hyperverbal or pressured. Like if I could not be interrupted and I just kept going, then that probably would be pressured speech. But if the therapist was like, whoa, 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 Lindsay, let's slow this down. Okay, you just shared a lot with me, right? You came in and you seemed okay. Then you talked about how you're feeling guilty about what happened between you and a friend, and now you're talking about your grief. Like, let's refocus this. What do we want to do in the session? If I was redirectable, that I need to get credit for that in your mental status exam, right? Like you need to say that Lindsay was hyperverbal, talked about these different emotions, but behaviorally was redirectable versus like I just kept going, like I bulldozed over you when you're trying to ask me more about this, then I probably would be pardon me, I probably would present with pressured speech, which would be indicative of a whole other thing. Again, typically I might be manic or under the influence of a stimulant. Um, People can be irritable, so easily visibly annoyed, labile, so highs and lows of emotions, not necessarily appropriate to situation. Somebody that's labile typically fluctuates on their own without a lot of provocation. And so we would see lability in terms of either mood stuff, if a person might be manic in the session, that's what that could look like. We also see that in terms of histrionic personality disorder, borderline personality disorder, that they have a lot of difficulty managing their emotional reactivity to things. Somebody that has premenstrual dysphoric disorder, that might be the case too. So it's really a matter of like, what's the roller coaster that they're coming in with as far as their presentations of their emotions. Sad, oops, sad, no, sad and stable. These are, sad is like, this is more situational than just depression. They're sad in the session based on talking about their deceased mother and they're redirectable and then they come out of that. Stable is stable, right? Like we're not concerned about their presentation. So you can attach stable to a lot of these different options. It's like if I know that this is contained, guilty, irritable, sad, maybe even dysphoric, I'm not worried about where this is going to go. Anxious or angry, I'm not worried about like what's going to happen to the client during the session or outside of the session. That's where you can say that it's stable. So affect, why do I keep doing this? Affect is how one actually demonstrates their emotions. So if I've been depressed for weeks and I come into this session and I'm despondent, then and it's because I'm going through like a lot of crap in my life, that's probably going to be congruent with the situation in session, right? Like if I'm despondent, but I just lost my mother, I have to go through her whole house and I have to sell stuff and it brings up a lot of emotions for me and like I just don't know how to get out of it and I'm continuously coming into session for help with that, then that's congruent with the situation. If I'm despondent and it's coming out of nowhere and you're like, "Whoa, Lindsay, like what happened?" And I'm like, it's the worst day of my life. Don't even talk to me. Like, I don't even know why I'm here. I don't even know how I got out of bed." And you as a clinician are like, whoa, whoa, whoa. Like, where is this coming from? Um, that could be a way of being incongruent in the situation. I use the example of like also being conversely, being happy in a sad moment where if a person has limited insight or they're disconnected from their presentation or their experience in some way, and you're talking to them like, okay, let's talk about your grief with your mom. And I'm like, oh, no, I'm actually good. Yeah, I know she just died and it was really terrible, but like, actually, like, I feel relieved. and that doesn't really seem to fit with the situation, then you would want to put that it's incongruent with the situation. So an affective um, is like affect is like a modifier to explain how somebody's emotions are coming out and whether that is to be expected or not. Sometimes, or I think that common ways of being able to speak to affect might be restricted. So if a person is uncomfortable, if they're not like fully open in the session, um, if their insight is needing adjustment, they need to like improve their insight, then they might have restricted affect. So they're sad when you know like, oh, this is kind of a really difficult thing that they're going through. So the sadness is coming out, but maybe they're not crying, they're not tearful, then we would want to indicate that their affect is restricted. So it's just not showing the full range of emotion. This is a pretty common one, to clarify or modify what I'm saying. This is a pretty common modifier that we would check. Now, blunted is it's like they're coming in to talk about their grief, but they've had such complex grief, or they're taking medication that is really, in one way, subduing them so that they don't totally spin out and demonstrate a lot of lability that maybe puts them into a panic attack or makes them go into a manic episode. But the medication can really blunt their affect, meaning that like they can't, it's almost like it's impairing their ability to actually demonstrate a more complete range of their emotions. Um, or if I'm like numb because I've been crying so much and talking about my grief, I'm going to stay on this grief thing for a moment. Talking about my grief and I'm like numb, then we're talking about sadness, but I don't have any more tears to demonstrate. That could be blunted affect because I just really don't have the capacity to demonstrate any sort of emotional range. Flat is on the other end of the spectrum. So if we start with like restricted, then blunted, flat is on the end where there's no emotional range. And we really see this again with the big three. This is what I'm going to call it. Schizophrenia spectrum, intellectual developmental issues, or neurocognitive issues. So neurodevelopmental or neurocognitive, this is where the brain is not wired correctly to be able to actually convey an expression of emotion. The other example of this would be if a person is heavily medicated, then they really may not be able to demonstrate what emotions they have, their sadness, um, their happiness, like that could really be impairing their ability to present in that way in the session. So if they're flat, and that could be incongruent with the situation that we're talking about. So we can ascribe congruent or incongruent to a full range of emotions, or restricted, blunted, or flat. Okay. How we doing? Great. So behavior, let's see. I'm not gonna read through all of these because I really tried to just give you an example on each of these. Um, uh, Avolition is something that, again, we might see with the big three. Catatonic is something that we might see with schizophrenia spectrum, or um, neurocognitive, or some sort of indication of due to another medical condition, pardon me, due to another medical condition. That might, there's a whole section that we'll talk about later on when we get into week 6, where we talk about catatonia. But so you may not be able, it's one of those things where you don't know it until you actually see it. We'll get there. Let's see, what was the other one that I wanted to say? Guarded. This is something that I would say you could experience depending on what population you work with. So my client that I was talking about that has delusional issues, that is probably under the umbrella of schizoaffective. He was especially guarded with me in session when what I was putting together was that when he was perceiving that this is under the scope of his delusion, his persecutory delusion, that I might share whatever information that he was talking to me about with this entity that was reportedly following him. He was guarded because he was not wanting to talk to me about how he was feeling. He was worried that I was going to turn him in at one point, that his parents were going to turn him in. So I would be like, hey, how are you doing? Like, how's everything been over this last week? Did you get out of the house? Did you get to see your family? And like, it was pretty limited in terms of what he wanted to offer me as far as content. And I could see that he was like checking in with himself about, I don't really want to share this. I don't think that this is helpful for Lindsay to see, because in the overall content of what was going on, it's like this could be used against me. So the guardedness is something that we could experience if a person does not have a lot of insight to why they're in the session, that they would probably be guarded too, or they don't have insight into the nature of their problems, and they, again, if they're paranoid, they might not want to actually give you any sort of thing that could be used against them. Grossly disorganized is what we would see again in like the big three. Let's see, hyperactive, we would see this in ADHD. Hypervigilant, this is something that we could see as far as PTSD. Interactive, this is like normal stage, like normal presentation. So they're interactive, they're actively engaging with others, like totally appropriate to the situation. Odd, this is say you know it when you see it. Restless, they can't sit still. If they're demonstrating any sort of punching, hitting, like attempting to hurt themselves in any ways, they're self-injurious. You would have to see this in session. This is, again, this is all stuff that you are documenting that is happening right in front of you. So it's not often that we actually see that type of behavior going on. But like I had a student last summer who was working at API, and the patient that they were really close to had a history of cutting, and they got called into the patient's room to help essentially re-regulate them, and the patient was trying to take, I think it was like a toothbrush or something. They were trying to take some sort of end of whatever they had available and trying to essentially like rub it against their arms in an attempt to be self-injurious. So that's what that would look like. But again, we have to see this. Sundowning, this is what we typically see with dementia, with Alzheimer's, that the later on a person, pardon me, the later on in the day is not good for those that have neurocognitive issues, because they start to decompensate. So in the morning, they are lucid, they have clarity in terms of their thoughts, their speech, but toward the afternoon, they start to become more dysregulated, disoriented, confused. So that's what sundowning is. You probably won't see it unless you are working with older adults, or if you have family members that you ever see toward the end of their lives, then that's what sundowning actually presents as. Suspicious, this could be along the lines of they're just suspicious because they don't know you and trust you, and they haven't had good experience so far with therapists, or this is happening because of their psychosis. Just depends on what the context is. Tearful, this may or may not be appropriate to context. So they might be labile and start to cry, but there's no reason that they really need to be crying. My 6-year-old niece gets inappropriately tearful all the time when she doesn't get something that she wants. So it just really depends on what the context is and who it's coming from. Now, if a person is uncooperative, they really don't want to engage, whether it's wanting or because they can't due to the nature of what's happening with their disorder. Unpredictable, they might be labile, violent, or assaultive. Hopefully we don't see this, but this is what, if you're working in a hospital or psychiatric setting, this would be a code green, that this patient or client is reacting to the environment. And the best, most clinical way to say this is that they don't have the skills and tools to be able to react appropriately, and so they become violent or assaultive. Most people do this because they don't have the coping skills, and it's like they're wounded animals, and so their violence, being assaultive or trying to be assaultive, comes from pushing people away so that they are not being put in a more uncomfortable position. Wandering, this could be because a person is catatonic, They have neurocognitive issues. Withdrawn could be somebody who's depressed, somebody who doesn't want to be in treatment, somebody who is starting to become more paranoid or is paranoid. It just depends. So there's lots of ways to be able to address a person's behavior. The point is we want it to fit. We want to use this as one puzzle piece in the big scope of their presentation of how we explain these behaviors in terms of what we're seeing in the session. So I did emotional ranges on the other side of this column. So anywhere from content to euphoric, that's what the scope can look like in terms of the highs. The lows can go anywhere from irritable, and we'll see this when we go through the handbook of the differential diagnoses. Irritable can be a lot of different things, sad, depressed, dysphoric, and despondent. Then I have given you an anger scale. Separately, things that we would see in the schizophrenia spectrum, these are behaviors that fit under the quote unquote positive symptoms. This is like commonly known as positive symptoms. We'll talk about that more in week 6 as well. But we'll see that when we do the practice round in class. So withdrawn, guarded, odd, suspicious, uncooperative. Those are all different components of what actively psychotic can look like. Negative symptoms, this is where it's like the depletion or depression of what happens in the brain under the scope of a schizophrenia spectrum presentation, is that there's diminished emotional expression. So they have blunted or flat affect. There's difficulty with their motivation. So that's avolition. They're apathetic. They're catatonic. They're grossly disorganized, unpredictable, even wandering. We could see that too. So it really is a matter of like, hey, based on what we know of, what's going on with this person in their disorder, then this is how they're physically showing up. So psychomotor, this could be, again, aligned with the behavior issues, with their mood, with their affect, just with how they're feeling in the moment. So if there's no movement issues, we'd see a calm appropriate to context, right? So like they're sitting calmly, they're not fidgeting, they're not restless, they're not agitated. We would say it's calm and appropriate. Now, if they are agitated or fidgeting, then that's where we could describe whether it's like because they can't sit still, because there's some sort of anxiety or discomfort. Motor retardation, there's like they're moving very, very, very slowly, and that could be based on schizophrenia, neurocognitive issues, medication. Shuffling, this is, I don't know, I was like, do we need to put this or not? But that's just in an older adult population, or if there's some sort of motor issues that are happening, we would see that too. Okay, last page. So this is where we get into the fun stuff, in my opinion, because this is where we start to see just a person's overall presentation become much more embellished. And with the thought process, this is like the mechanics of how they're actually speaking to you and with you. And this is an indication of what's happening cognitively to them. The thought content is the type of thoughts that they're actually having. So the thought process, these mechanics can happen in a scope of disorders, anywhere from depression to anxiety to mania, schizophrenia spectrum, neurodevelopmental, neurocognitive, just a plethora of different, or even just personality stuff. Like it just totally depends. So thought content is what we would more so see in schizophrenia spectrum, or some sort of paranoia that's happening secondary to something else, maybe being under the influence. Perhaps we see this even with like more progressed dementia or Alzheimer's. People become paranoid because they're really not oriented and they're not able to use the executive functioning part of their brain. But so this is where we would see how a person shows up in terms of how they're communicating their thoughts to you. So under thought process, give the example of a road, to me, this is like the easiest way to be able to describe this. Like if I have organized linear thoughts, then it's like I'm getting on the freeway and I'm driving from San Diego to Orange County. And I get in my car, I bring all the things that I need for my trip. I have enough gas in my car and I get on the freeway and I get off at Beach Boulevard. I don't know. And that's the straightforward process, right? So that's organized, intact, linear, and logical. Those are the ways that I would, because it means that there's no issues with managing my thoughts. Like I can demonstrate executive functioning. It's straightforward, so it moves from point A to point B. That's really used as like a metaphor of like if you ask me a question and you say, hey, can you describe what your childhood was like? Like, well, it was pretty difficult. My parents were both emotionally absent. They did the best that they could, but I still really struggle with a lot of sense of myself and sense of self-worth because of how absent and reactive they were during my childhood. That's a very linear explanation. And it's logical too, right? Like it makes sense in terms of why I'm saying one thing as it relates to the other. Now, if I'm just going to go with this. Well, I'm kind of doing a little bit of, I'm getting a little bit disorganized right now because now let me back up and do the road situation. If I am not able to get from San Diego to Orange County in a straightforward linear motion, then I might be turning around. Like I'm like, where am I going? What am I doing? I'm confused about what I'm supposed to be doing in the car in the first place. I might be disorganized where it's like nothing, like keep getting off the freeway and then I get distracted and I get confused and turned around, and instead of me going to Beach Boulevard in Huntington Beach, I just go left and I just go to the beach. That could be disorganized, or I might be forgetful. Like you said, beach, I'm going to the beach, right? I think that's what you said. Or maybe I have like a flight of ideas of like, well, let's go to the beach. Okay, so supposed to go to Orange County, but like, oh my gosh, I haven't been to the beach in forever. Let's just like go to Ocean Beach. Oh, you know what? I need to stop off the freeway after I get off and like go to the CVS so I can get my medication so that I'm not going, and then get sunscreen so that I can actually like not be um get sunburned when I'm at the beach. And then, oh shoot, I need to go bikini shopping because I don't even have a bathing suit. On and on and on. That could be fragmented where I have such difficulty in terms of like completing actual thoughts, and disorganized where like I can't stay focused. What is another example of that? That could be like loose associations where like I'm actually like not putting coherent ideas together. The flight of ideas, going back to that, is, sorry, I hope I'm not too disorganized in all of these things that I'm throwing out. Um, the flight of ideas, that's something that we see of like, oh, let's do this and let's do this. And then, oh my gosh, oh, let's do this. Something that we could see with mania. This is something that's usually typically what we could see is when somebody is increasingly more elevated, they can't stay focused from point A to point B. Okay, backing up, let's just say that going back to like this example of if you're asking me about my childhood. Now, if you're like, hey, describe to me what your upbringing was like with your parents, how was your childhood? And I'm like, oh gosh, let me tell you about this. Well, when I was 5, this thing happened where like my mom just had to work a lot and she really decided that she did not want to be a mom anymore. And so she just spent much more time out of the house. And oh yeah, she was spending much more time in the house, and she's hanging out with this one friend a lot, and they were drinking a lot. And so she just was like really gone. And I'm telling you this like really long-winded roundabout way of getting to the point, but I eventually do. Like 15 minutes later, I'm like, and that's how my parents were very absent from me. And that's how I really have a lot of self-esteem issues. But I like take the long way around. So that would be equivalent to like if I say, hey, you need to go from San Diego to Orange County. And I'm like, you know what? I'm not going to take the 5. I'm actually going to get off the freeway and intentionally take the 101 all the way up. It still gets me there. I think. But it takes so much longer than it needs to, right? Like I'm still in the direction and I know I'm going in that direction, but it's unnecessary how long it takes me. Now, when you're in the session with somebody who's circumstantial, you might have to be like, hey, I love all the details that you're sharing with me, but let's go back to the point. Tell me again. You're giving me so much information and it's helpful for me to hear this in one way, but just due to the nature of our meeting today, let's get to the point. Help me understand what you're trying to say with this. And hopefully your client or your patient's gonna be like, oh yeah, okay, I just have a lot of trust issues because my parents were largely absent in my life. That makes sense. If a person has thought blocking, again, that's where their thoughts might disappear or vanish. I'm going up a little bit. If they're demonstrating abstract thoughts, it's almost like parents. I don't know about my parents. Where did this come from? Why are you asking me about this? It's like, well, you're talking about relationships. Well, my parents, they work. Okay, like it's not clear to context, it doesn't make sense, it's not concrete, that could be abstract. The thought blocking, again, is what we would see in a schizophrenia spectrum, or even like severe anxiety or severe distress, where the person cannot hold on to their thoughts. It's almost like they just disappear in their head, and they can't recall them, like if they don't come back, they're just gone. Concrete is if I'm like, hey, go to from San Diego to Orange County, and the concrete would be like, well, if there's no, if on the way to get there, there is construction on the freeway and they have to take a detour. Somebody that's concrete would be like, well, you told me to take the freeway and I need to take the freeway and I can't take the freeway, so I don't know what to do. Using critical thinking is like, I got to take the detour, but I'm still getting toward my destination, but the path has just changed. Somebody that is thinking concretely really does not have the ability to like exercise critical thinking, which this could come from a thought disorder. This could come from neurocognitive issues, neurodevelopmental issues, that it's tough for them to make decisions that use critical thinking because of how they are in the moment of being concrete. If they're confused, and this could be again from the big three, it could be because you're asking them stuff that's over their heads because of their insight. They're confused because they're sleepy. I don't know. There could be a lot of reasons that a person is confused. Could be medication. Disorganized, that they really cannot get from San Diego to Orange County, like I said earlier. We talked about flight of ideas. If they're forgetful, the fragmented is like they're not giving you complete sentences or statements of like, well, let me tell you about my parents. It was really tough. What was also really tough was me being in first grade and getting along with my classmates, and maybe I don't even give you that clear of thoughts. What might be difficult is me being in first grade, and then I had a puppy, and then I rode a bike, which this can go into tangential thoughts, so disorganized, get disconnected, that are deviating from the task at hand. Illogical, it just does not make sense. Like we talked about linear, logical, loose associations is like really derailed. So it's like just it's along the lines of word salad, where it's just random thoughts thrown together. We would see this again in that big three of more significant thought issues mechanically. If somebody's perseverating on something, so it's almost like, they're having the same thoughts, ideas on repeat. That could come from somebody that's like just hyper focused and anxious, or somebody who's in distress and they want to just keep telling you the same story over and over and over again. Somebody who's on the autistic spectrum, they perseverate on a lot of thoughts, ideas. It's basically like the equivalent of I tell you to go from San Diego to Orange County, and you just once you get to Orange County, then you come back to San Diego and you do it again. And I'm like, no, 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 like you just need to go there once, and you just keep doing it again and again and again. So it's like this loop where we have to try and interfere with that. And again, I talked about tangential too. So I think my thought process was somewhat disorganized as I was going through this with you, where I was not necessarily like going from San Diego to Orange County so clearly. Part of this comes, I think, from my attention deficit. But hopefully that made sense. Whatever questions you have about this in class on Thursday, let me know. So thought content, this is a little bit different. So a person can have disorganized thoughts. They could be forgetful. They could have tangential thoughts where they just can't make up complete thoughts and sentences. Separately, the nature of their thoughts, it's like basically how they're thinking, what they're thinking about. It's not a matter of how they express these thoughts to you. So if it's appropriate to content, there's no disturbance in terms of the types of their thoughts. If they are experiencing depersonalization, this is something that we see in the dissociative disorders section specifically, where they're disconnected from their self. If they're grandiose, they have an inflated sense of themselves. Ideas of reference, they believe that what's happening in the world actually is happening because of them, or that they are involved in the story.
This is where I didn't like the example that I used, but essentially, ideas of reference is if an example would be if somebody is watching the news, or if people don't watch the news anymore, reading about the news, the ideas of reference are that they believe that things that are happening in the world have something to do with them, or that people are actually talking about them in news stories when that is completely not true in reality.
Intrusive would be if a person is feeling like paranoid, persecutory thoughts, which means that like the nature of their thought content is that people are against them. And we would see this with auditory hallucinations as well, of these intrusive paranoid thoughts. There are voices that are coming into their thoughts that are getting in the way of their concentration, of their focusing. These are unwanted thoughts that make a person feel like they're being followed, that people are out to get them, that they're interrupting in terms of their thought process. So intrusive thoughts, it's like, get out of here. And it's much more distressing than that. It's like, oh my gosh, please, please stop talking to me like this, voices, or these thoughts that I am disgusting, that I smell. My client that again, I think has schizoaffective disorder, have these intrusive, really paranoid thoughts that that he was malodorous, and he wasn't at all. Like I'd never. So the first time that I met with him, he was like, "Hey, I'm really anxious to come into session because I think that I smell, and that you're going to smell me, and you're not going to like it." And I was like, "What are you talking about? Like smell fine." And I have like a very keen sense of smell. And there are these intrusive thoughts that he had, that like he was dirty. That was the intrusive thought. And then it came out in terms of paranoia that there was something that was actually wrong with him in terms of his hygiene. Um, so that was really tough. Magical thinking, it's almost like if I am that I think that I have the power to cause events that happen. Like I have the ability that if I think, okay, magical thinking is very commonly seen in the hospital, in all hospitals, where the magical thinking is if you say it's a slow day or it's quiet, that it's going to jinx the outcome of the situation, and that if it gets busy, it's because I thought this and I put this out in the world and then it happened. I know that there's something to be said about manifesting our thoughts and like really trying to like send out like good vibes and good energy. Magical thinking takes it a step further. Is like I have the power to change events based on something that came up in my mind, whether that's like a spontaneous thought or whether it's something that I've been sitting with. For anybody that's seen the original Ghostbusters, like from the 80s, there's a scene where this demon is like, clear your minds, or no, the demon is like, choose your destructor. And they're like, clear your mind, don't think of anything. And Dan Aykroyd thinks of the Stay Puft Marshmallow Man because that's what comes into his mind. That is like a good example of magical thinking, is that if I think it, I will make it happen, and it will typically be destructive. Magical thinking is not necessarily good thinking. It's that something like bad is going to happen because of what I came up with in my mind. Paranoia is a belief that somebody's after them, that people have some sort of malintent toward them. Phobias, these are excessive fears that we're going to talk about when we go over anxiety and OCD section. Religious preoccupation, this is like a hyper focus on religious themes. We very much see this within delusions, schizophrenia spectrum. This is where there's like this constant tug and pull between good and bad, or people are like very hyper focused on God as their savior and protector, but it's like much more to an extreme extent as far as the context of this. So they are like, or a lot of people believe that they are like sent as like the Messiah, or that they're sent to be the messenger to Jesus. Like that kind of talk is what we would see in religious preoccupation. Thought broadcasting, we're going to see this in the video. It's the clinician is going to ask if the person believes that their thoughts are actually being displayed so other people can read them, other people know what their thoughts are, or thought insertion, where people can actually read people are putting messages into their mind. And the subtext to this is that when people are agreeing that thought insertion was what is happening to them, their sense is like, yes, messages are being implanted into my mind and they're going to be used to control me and other people. So typically we see one or the other with delusions. Sometimes we see both, but that's what we want to know. Is it's like, hey, what's going on with your thoughts? Do you think that other people can actually read them, like they're like on display, or are people actually controlling your thoughts? Are they telling you what to do? Are they telling you what to say? Are they telling you to do this and this? So again, my schizoaffective client was very much along the lines of experiencing thought insertion, where they thought that the entity was trying to tell them to possibly die by suicide or hurt others. This case got really complicated, and I, again, hope that this person is okay. I've done everything that I need to do as far as demonstrating due diligence to let the people that need to know about potential safety issues know that. But my client kept saying, I'm never going to do anything to myself or other people. Like, I would never do that, but I'm in distress because this government entity is telling me to hurt myself and other people. That's thought insertion. So delusions types, we're going to go into this when we get into week 6. But what we commonly see are persecutory delusions. So again, this is the belief that somebody is actually after them, that they're being monitored, that somebody's out to get them. And then, so with these 3 sections, I'm realizing it's important to recognize that if we're concerned about this, we have to ask about this in session. If we're doing an assessment, we want to go through the motions and ask about this. Now, somebody can identify that they're experiencing these delusions. They can also state that they're experiencing hallucinations. So they might confirm that, yes, they're hearing voices, they're hearing sounds, they're hearing whispers, they're seeing things, people, shadows, objects are the common things. They're feeling things. So my schizoaffective client kept feeling like this like tapping throughout the day. So that's a tactile hallucination. They might be smelling what's not there, tasting what's not there. This is more rare. The voices might be telling a person what to do, or the voices might be threatening or abusive. And so this is where it's like really intrusive thoughts that a person is experiencing that, again, are very distressing. Now, you may know this about a person based on their history, based on what they've said to you or to somebody else in an assessment, what they've told, again, somebody else in assessment, but in the session, they might be denying it. So perhaps that you can see them responding to external stimuli. They're distracted in the session. They're not maintaining eye contact with you because they're responding. And then they're starting to get distressed. But when you say, hey, what are the voices telling you to do? It seems like you're really overwhelmed. And they're like, voices aren't talking to me. Nobody's saying anything to me. Okay, well, why are you getting distracted? I don't know. Okay, I'm concerned. I'm confused. Nope, nothing's happening. So that's where you would put denies, because not everybody is forthright with the nature of their hallucinations in terms of what they're experiencing. But most people will actually admit to it. It just depends on the nature of the relationship, on the degree of difficulty that they're experiencing, on how paranoid they are, for instance. So you have the opportunity to actually identify if they're denying it while still checking that you know that they're hearing voices because they are uh, responding to internal stimuli in the session, for instance. But it just gives us the ability to really modify or really specify what that looks like based on what our overall observations are. Okay, so I'm going to just bring this back to this last example again. So I hope this makes more sense now as I reread this example, the second example of Pedro. Pedro presented to the intake session as alert and oriented ×4. He was slightly disheveled and malodorous. His memory was unable to be assessed. His judgment and insight were fair throughout the session due to the nature of his thought contact. He made little eye contact with me and seemed to be responding to internal stimuli during the intake. His speech was soft and he mumbled until I asked him to speak more clearly. Pardon me. Pedro's mood was dysphoric. His affect was blunted, but congruent with the situation. His behavior was suspicious, guarded, and withdrawn. His thought process was illogical, tangential, and he was likely experiencing thought blocking, as evidenced by his reports. I don't know where what I was just going to say just went. He admitted to paranoid thought content, as well as ideas of reference and magical thinking. And there you could explain, you could give the example. The paranoid thought content is like people are out to get him, and also because they're out to get him, that what's happening with this car chase on TV is really that they're trying to find him and they're looking for him because he sent a message to the Prince of Arabia. I don't know, something like that. You could further explain that if you wanted to in that sentence. He denied any hallucinations, but it was evident per his behavior that he was experiencing auditory hallucinations during the session due to his behavior of responding to internal stimuli. His psychomotor presentation was restless, as evidenced by his right leg shaking throughout the session and fidgeting with his pen. Now, when I say all of this about his thoughts, it makes sense how this is coming out in terms of his restlessness, right? Like that if he's anxious, if he has voices that are talking to him, and he is thinking that he has a lot of control over the world and things are happening that are bad because of that, and then he's worried about how this information is going to get out, we would probably be restless too, right? And fidgeting with things too, right? So that is meant to give context and to continue to really build out this image of why he's showing up physically the way that he is. I hope that that makes sense. Thank goodness Pedro is denying any sort of past or current suicidal ideation or homicidal ideation. And in the session, he comes in with his wife. And so that's really like a little Easter egg too of his wife is very, well, what does that tell you? Me adding this in, confirmed by his wife. Why would his wife be in this picture at all, right? She's concerned. He's probably not functioning very effectively in the world, right? If he's paranoid in session with you, he's suspicious, guarded, and withdrawn, but perhaps he is much more open about the nature of his thoughts with his wife, and she's really concerned about this. So this is our way of really speaking within 5 words of the fact that we're concerned about him because of his presentation. And we've either included the wife in the session, and when we've asked him, hey, Pedro, are you feeling suicidal? Are you having any sort of thoughts to hurt yourself or anybody else? And Pedro says no, we might look over to the wife and be like, hey, do you have any other information about this? And she's like, no, 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 he hasn't expressed any of that. Or perhaps we get off the phone and we're like, we have a release of information for her, and we're like, hey, so and so, we're really concerned because of all these things that happened in the session. Do you have any indication that he is a danger to himself or others? Has he said anything like that in terms of his thoughts or what the voices are telling him to do? And she's like, nope, nope, thank goodness I asked him because I'm so worried about this. So there's a lot to be said, as confirmed by his wife. So this is my example to show you how we can say a lot about how a person is showing up in front of us in one paragraph. Okay? All right. So I've said a lot. I've said a lot. Thanks for staying with me. Please, if you have any questions about this, let me know. We'll talk about it in class, and then we'll do a dry run of practice. Okay? Thank you, everybody.